Good morning, ladies and gentlemen. Thank you for letting us present our study from the Royal Cornwall Hospital, examining the necessity of post-op X-rays and blood tests in routine hip and knee arthroplasty. We have no conflicts of interest to declare. At this year's British Hip Society meeting, the Northumberland group presented a session on day case hip and knee arthroplasty. It transpired that they undertook no post-op radiograph until 6-week clinic appointment. When questioned about the evidence base for this, they said they had none, but anecdotally had no issues. With respect to post-op blood test, they felt these were probably not always necessary either, but in the absence of evidence, still perform them. This got us thinking, especially when a literature review revealed a dearth of evidence on this matter. So why might this be an important question? Though minor, blood tests and radiograph have the potential for causing harm. We know they can cause delay to discharge, and finally, there is both a monetary and staff time cost undertaking them. Our study aims to explore a subgroup of fitter ASA 1 and 2 patients to determine who of those need blood test and whether radiograph can be safely delayed. We undertook a retrospective review of all ASA 1 and 2 patients undergoing primary hip and knee arthroplasty at our hospital. We looked at pre and post-op bloods, and if any abnormality was found, an in-depth review of the notes was undertaken. We also reviewed post-op radiographs and notes to see if they resulted in either a return to theatre or change in rehab protocol. After data cleaning, we had 612 procedures for review. The mean age was 66 with a slight female preponderance. Again, there was a slight preponderance of hips over knees. The vast majority were ASA2. In terms of outcome measures, of our 612 procedures, 5.7% returned on hemoglobin less than 10, 2.1% developed acute kidney injury, hyponatremia and hypokalemia was present in less than 1%. Of those with low hemoglobin, only 4 were symptomatic and required active intervention in the form of blood or iron infusion. 13 developed AKI. Of those, 11 had pre-existing renal disease. The 2 patients with normal pre-op renal function both had prolonged post-op hypotension as well as an extra kick to the kidney with a little bit of PR Voltrol. Of the 2 hyponatremic patients, one had pre-existing renal disease. The other had drunk over 2 liters of water in the first 6 hours. Of the 2 hypokalemic patients, one had alcohol issue and metabolic syndrome. In the other, there was no clear underlying cause. We found that on no occasion did a post-op radiograph alter subsequent management. So, in conclusion, are post-op bloods and X-ray needed in ASA 1 and 2 hip and knee arthroplasty patient? Not always. Our study suggests blood tests are needed if patients are symptomatic or if there is clinical concern, patients have pre-op renal dysfunction, there is prolonged post-op hypertension, patients suffer with metabolic syndrome, or there is an excess of fluid intake. As per Northumberland's hunch, radiographs may be safely delayed. Thank you.